right, it's a fresh week. Time for the quick quiz of the week. We have a patient arriving as a full trauma alert. He comes in unresponsive, no eye opening, incomprehensible sounds, withdrawing from pain. Blood pressure's fine, heart rate's elevated. What is the next best step? So, choice A, intubation with inline stabilization. Choice B, video-assisted enterotracheal intubation with C-collar on. Choice C is to do an EFAST. And choice D is to do a chest x-ray. Why don't we mull this one over for a second? All right, so correct answer here is going to be choice A, intubation with manual inline stabilization. So we're talking about trauma patients here who have cervical spine injury or suspected cervical spine injury. ABCs always in order. So what we have here is a GCS less than 8 in this patient with a high suspicion with the mechanism concerning for C-spine injury. Now, 10% of all trauma patients with a GCS less than 9 will have a cervical spine injury. So always assume that it could be there. What you want to do here is maintain cervical spine stabilization, doing manual inline stabilization, also known as MILS, M-I-L-S. Clever, right? So the collar should come off the cervical spine when you're intubating. You can do direct, but it requires more mouth opening. Video is preferred based on the studies, based on patient outcomes. The person holding the C-spine needs to crouch beside the intubator with hands placed on the patient's mastoid processes. You can also stand beside the patient and lean over in front of the intubator with hands placed on the sides of the patient's head and the forearms resting on the patient's chest. Shouldn't keep the hard collar on. The hard collar will limit grade viewing, limits the mouth opening, and worsens cervical spine movement based on studies. It's kind of like crouching doctor, hidden C-spine instead of crouching tiger, hidden dragon. Anyway, that's all I got. Check out EM Rapid Bombs right below. Thanks again.